Good evening, everyone. I am Dr. Ahmedi. I am working as Associate Professor in the Department of Anesthesiology at Aditya Institute of Medical Science. I am thankful to the organizers for giving me this opportunity. My topic will be complex regional pain syndrome, its management. So let's begin. Coming to introduction, CRPS is not a very common condition. It's quite an uncommon condition, and the symptoms can mimic a large number of other possible conditions. That's why it can become difficult to sometimes diagnose it. And this is how a CRPS can feel. And there's always some amount of delay in diagnosing and starting appropriate therapies. Now, what is the differential diagnosis of CRPS? Because we have so many constellation of symptoms in CRPS, we can have various differential diagnoses. Let us see few. Like neuropathic syndromes, it can resemble a peripheral neuropathy, postherpetic neuralgia, deafferentation pain, or it can resemble some peripheral vascular disease. It can resemble an infection or an inflammation, a cellulitis, or any rheumatological diseases, or it can also resemble a myofascial pain or sometimes psychiatric problem. And because there are so many symptoms, patient keeps moving from a specialist to another specialist, and in the process, he may end up he may go to so many specialists, like you can see over here. Now, coming to diagnosis, there are no proper gold standard diagnostic tests. The most important thing is prompt diagnosis and early treatment. So that is the best thing to prevent complications. We can do other tests just to rule out the other differential diagnosis. Like you can get a CBC, ESR, CRP to rule out an infection, or you can get a Doppler to just rule out a peripheral vascular disease, nerve conduction studies to rule out nerve involvement, or to confirm a nerve involvement in CRP2, and plain X-ray to just demonstrate osteoporosis, though it is not of very significant value. There are certain tests which can be done in CRPS. Let us see those. Quantitative sensory testing, which will provide information of sensory, thermal, pain and vibratory thresholds, and this will assess the large and the small afferent fibers. Test of autonomic function. Because we see there's a lot of autonomic involvement in CRPS, we can do certain tests, like measuring the skin temperature by infrared thermometry, or measuring the sweat output, that is the pseudomotor regulation, which is tested by quantitative pseudomotor axon reflex test, or also the imaging for trophic changes. The best thing is three-phase bone scintigraphy, which may demonstrate increased uptake of technetium due to increased bone metabolism, especially in periarticular region. Coming to management proper. Now, when we manage, we have to manage all the symptoms which are involved in CRPS, like pain, edema, trophic changes, motor or sensory deficits, and psychological impact. It is always a multimodal and multidisciplinary approach. Treatment should occur immediately. That's how you can prevent the complications. And it should always be directed towards restoration of full function of the extremity. Now, what is there in CRPS management? What are the different modalities? Let's see. We have rehabilitation, which forms the core of CRPS management. Now, rehabilitation will have physical therapy, occupational therapy, vocational therapy, recreational therapy, psychotherapy. Then we have pharmacotherapy, and then we have interventional therapy. It's not like you just have to start with one and go to the other. You may have to do a combination of all these. Like when you're doing a rehabilitation, the patient should be pain-free. So at that time, you may have to start pharmacotherapy, and if that is not helpful, you may have to go for intervention. So you may have to start with intervention, go for pharmacotherapy, and at the same time start with rehabilitation. So everything goes in hand simultaneously. This is a simple algorithm for diagnosis and treatment. So when you diagnose CRPS, you start physical therapy. Now see which is a prominent mechanism. Like if you see there's more of inflammation, go for anti-inflammatory drugs. There's more of pain, go for analgesics, interventions. Vasomotor, go for vasodilators. There are motor disorders, go for muscle relaxants. And if the conservative treatment is not adequate, sufficient to control the pain, go for interventions. If the interventions also fail, then go for something called as neuromodulation, which we will talk about later. Now, what are the pharmacological options we have? We have various options for CRPS which have been studied, like NSAIDs, anticonvulsants, antidepressants, opioids, sodium channel blockers, corticosteroids, NMDA antagonists, bisphosphonates, free radical scavengers, and other drugs like vasodilators. There is no specific agent which is the drug of choice in CRPS. All these drugs have been very beneficial in other neuropathic conditions or other inflammatory conditions, and they have been tried in CRPS with variable results. Like NSAIDs. NSAIDs may be effective against mild to moderate pain as anti-inflammatory agents, that is in the acute phase, but they are quite inferior to other agents. Opioids again may be effective in acute phase to reduce pain, but not for chronic pain. They are not very good favorable agents, especially in CRPS, but it can still be added with other drugs to reduce the pain. Corticosteroids as anti-inflammatory are one of the best drugs because they have been shown to reduce significant edema and also pain score in several RCTs. So oral prednisolone is very effective in inflammatory phase. Then IV lignocaine has shown promising results with reduced spontaneous and evoked pain. And NMDA antagonists like ketamine infusion has also shown significant reduction in pain. IV lidocaine and IV ketamine infusion can be used together for severe chronic pain in CRPS. Other drugs like calcium regulating drugs, bisphosphonates. Bisphosphonates have a very important role in CRPS. The trophic changes which occur, the osteoclastic activity which is happening in CRPS, that can be controlled with bisphosphonates. It prevents bone resorption and it causes significant reduction in pain and also improvement in range of movements. Some of the agents are clodronate, alendronate, and pamidronate, which have been used successfully in CRPS. Next is calcitonin. Intranasal calcitonin in few RCTs have shown to provide good pain relief, but the meta-analysis have shown conflicting results. It can still be tried. Next, we have free radical scavengers like dimethyl sulfoxide. 50% topical dimethyl sulfoxide application has shown to reduce inflammation and symptoms, and it has been more effective for warm type of CRPS. And N-acetylcysteine consumed orally has been shown to be more effective for cold type of CRPS. Vitamin C. Now, vitamin C may not play an important role in treating CRPS, but it has shown that vitamin C can prevent CRPS. In patients who are prone for CRPS, like in patients who have fractures or any other things, vitamin C can be started early to prevent CRPS. Next is anticonvulsants like your gabapentin and pregabalin. Gabapentin and pregabalin have been used widely in treating a lot of neuropathic conditions. And even here in CRPS, which is considered a neuropathic condition, these become the first line of drugs. They are also very effective in reducing sensory deficits along with pain. Carbamazepine has been successfully used in trigeminal neuralgia, but it has not been shown to be very effective for CRPS. Antidepressants like tricyclic antidepressants such as amitriptyline and nortriptyline have also been effective against neuropathic pain. If they are combined with gabapentin and pregabalin, the results have been better. SSNRI like venlafaxine has also shown some effect, but not used very widely for CRPS. And if the mechanism of more of vasoconstriction, we can use vasodilators. Like tadalafil, a phosphodiesterase inhibitor, has shown beneficial results in cold type of CRPS. So when we have moderate to mild to moderate pain, we can use simple analgesics or blocks. Excruciating pains, you can go for blocks, opioids or other drugs. When there is more of inflammation, swelling and edema, anti-inflammatory drugs like steroids are much better. When there is associated depression, you can go for antidepressants and sedatives. Significant allodynia or hyperalgesia, you can go for anticonvulsants. And when there are trophic changes, calcitonin and bisphosphonates have shown very good results. And when there are profound vasomotor disturbances, go for vasodilators. This table shows the various drugs, RCT of the various drugs used in CRPS. As you can see here, gabapentin, IV lidocaine, prednisolone, and bisphosphonates, DMSO, and N-acetylcysteine, IV ketamine have shown very positive results. Next, coming to interventional therapies. So what are the interventional modalities we have? The first and the foremost is sympathetic blockade, like stellate ganglion block for upper limb and lumbar sympathetic block for lower limb. Next, we have neuromodulation, that is spinal cord stimulation or peripheral nerve stimulation in case of intractable pains. And intrathecal medications like baclofen, ziconotide, and sometimes opioids. Coming to sympathetic blockades, these are the first line of interventional therapy. Like stellate ganglion block is used for upper limb and lumbar sympathetic block for lower limbs. It can provide a significant reduction in pain by blocking the sympathetic pathway of the pathophysiological stages in CRPS. We have seen that CRPS has a very major sympathetic involvement, nervous system involvement. So blocking that will help in reducing pain. But the problem with this is the relief is short term. So it may have to be repeated multiple times or leave an indwelling catheter and keep giving the injections. And for long-term results, we can go for radiofrequency ablation of stellate ganglion or lumbar sympathetic trunk. Now this is a picture showing stellate ganglion block, USG guided stellate ganglion block. The sympathetic blocks are performed so as to provide enough relief to the patient so that they don't have pain and they can cooperate for physical therapy, exercises for functional restoration. Sympathetic blockade is not used as a sole therapeutic modality. Only giving a sympathetic blockade will not help in CRPS. They are just a part of the treatment where when the pain is reduced, the patient is able to do his rehabilitation in a better way. While we do stellate ganglion blocks, we have to keep one thing in mind. 20% of the patients will have sympathetic fibers that bypass the stellate ganglion block, and these are called Kunz fibers. Now, these patients may not achieve sympathetic blockade with only stellate ganglion block. That time, we may have to go for blocking the Kunz fibers to achieve proper sympathetic blockade of the upper limb. So that's why we give T2 to 3T sympathetic chain blockade. In this way, you will achieve a complete sympathetic blockade of upper limb. In case your sympathetic blockade fails, radiofrequency ablation of the sympathetic trunk also fails, and the pain is intractable, patient is unable to do his rehabilitation, the next better thing which you can think of is neuromodulation. Okay. In neuromodulation, the most common thing is spinal cord stimulation. Remember, this interventional modality is used only in case of intractable refractory pain, which has not improved with any of the medications, any of the interventions. Because this is an invasive procedure and it has its own adverse effects, it's not done easily in everybody. We have to first assess the patient properly, and there are certain criteria that the patient should fulfill. Only then we go for this. So this is like a last resort. Now what happens in spinal cord stimulation is we have a spinal cord stimulator which has a generator and there are leads. These leads are placed in the dorsal aspect of the spinal cord, and these are placed within the level that innervates the area of pain. And this has been widely used for control of intractable pain in many chronic pain conditions. Here you can see the leads. Here in this picture you can see cervical leads. In the previous picture the leads are mostly in the lumbar region. Now how does the neuromodulation act? It may act to restore normal GABA levels in the dorsal horn and also affect the release of adenosine and hence reduces neuropathic pain. It has proven effective in supporting functional restoration in the affected limb in CRPS. Next in neuromodulation, we have peripheral nerve stimulation and motor cortex stimulation. They have limited effectiveness. They are not as effective as spinal cord stimulation. Especially peripheral nerve stimulation may be beneficial when there is only localized pain involving one nerve involvement along the distribution of one nerve. But in CRPS, it will be more of multiple involvements, multiple nerve region involvement, multiple dermatomal involvements. In that case, the peripheral nerve stimulation may not be effective. So this was about neuromodulation. Next, we have intrathecal treatment. When the pain is very severe, it is not controlled with all these other interventions, then you can think of intrathecal morphine or even epidural clonidine has also been tried. But the requirement is so high that it comes with its own adverse effects. And also baclofen has been used intrathecally, especially when there is dystonia. This has shown to reduce pain and dystonia in CRPS patients. Another drug of interest is ziconotide, intrathecal ziconotide. What is ziconotide? It's a peptide found in sea snail venom and it's an N-type calcium channel blocker. Now this has shown significant reduction in edema, trophic changes and pain, but it is associated with several side effects. That's why ziconotide is not advocated to be used in all patients. That was about the intervention. Next, coming to rehabilitation. Rehabilitation forms a very important part of CRPS management. So what is the goal? To overcome kinesiophobia. What is kinesiophobia? Patient has the fear that if he moves, he will have pain. So he has to overcome that fear, increase use of affected limbs, and provide adequate analgesia, encouragement, and support throughout. Okay. The other goal is functional restoration. And like I said, it should always be multidisciplinary approach. Now in rehabilitation, we will have physical therapy, occupational therapy, recreational therapy, vocational therapy, and if need be, psychotherapy. In physical and occupational therapy, how we start is we initially minimize edema by massage, limb elevation, or use of some specialized garments or wrapping. And then we initiate gentle active movements. Then we do desensitization. For desensitization as in the abnormal sensation which the patient has in CRPS, he should come out of that and start feeling normally. That is desensitization. Now, what are the things we can do? Mirror therapy. Mirror therapy has shown to have a significant effect in CRPS. What is done is, there is a box, there is a mirror. Okay, you keep the affected limb in the box. In front of that, you keep a mirror. Okay, in front of the mirror, you keep the unaffected limb and start doing the activities, looking at the mirror. When you move your unaffected limb and look at the mirror, it is as though your opposite limb is acting. Now, this tricks the brain into thinking that your affected limb is also moving and doing all the actions. So in this mirror therapy, you can do all the activities. You can start with simple movements, to typing, to writing, everything, because you're doing it with an unaffected hand. And this will start desensitizing. You will start thinking that your affected limb is doing all the work. Other thing which can be done is you start touching, you ask the patient to touch and feel routine things with both his hands. First with the unaffected, then with the affected. And some things of different structures and different textures like smooth, rough. So over a period of time, the sensations will become normal. Next thing is stress loading. In stress loading, we teach them to do something like scrubbing, What is scrubbing? A simple scrubbing, like back and forth movement. Initially, he can do it only plain back and forth movement. Later on, over a period of time, what you can do is you can start adding weight in the hand. Simple weight to slightly more, slightly more. With that, he can do back and forth movement of his hand. And the next thing is carrying weight. Like initially you give them some simple weights to carry, and then you can go on increasing the weight as and when the patient improves his movements. And apart from this, you can give him some active exercises and also make the patient do mat exercises or aquatic therapy. While doing rehabilitation, several patients may complain of myofascial pains. Now, these myofascial pains have to be managed by ultrasonic massage or trigger release or injections or transcutaneous electrical nerve stimulation. Now, in spite of all this, with rehabilitation and everything, if the patient is still having pain, then what we do? We have to look for any psychiatric causes. Okay. Look for if he is going into depression, anxiety or anything. And if it is so, then manage that with relaxation techniques, coping skills or behavioral intervention. And if there is good progress, then he can be discharged. If there is no progress, then it has to be continued. The cycle has to be continued. Now, this is the summary of what we learned till now, like diagnosis of CRPS. When it is diagnosed, start treatment as early as possible. You have to start rehabilitation and, if need be, psychological pathway. Yeah. So that was about the management. We have certain emerging treatments which are undergoing trials in the management of CRPS, like immunomodulators or anti-cancer drugs, because we know it's an anti-inflammatory component which plays an important role in the pathogenesis of CRPS. So a lot of drugs are under trial. Other thing is hyperbaric oxygen therapy and Botox for spasms and all, and plasma exchange. Thinking the autoimmune aspect of CRPS, plasma exchange has also been tried. All these are under trial and they have shown benefits in some and not very effective in others. They are still under trial. So this is about CRPS management.